Module 4, Immunity and Infection. We're going to talk about Chapter 22, Coordinating Care with Patients with HIV. HIV, Human Immunodeficiency Virus. So this is a retrovirus that causes immunosuppression. The target cell for this virus is CD4 plus T cells. I'm going to show this video now so it gives you a nice overview of how this virus invades our cells.
When HIV first enters the human bloodstream, the virus circulates throughout the body. The protective surface of HIV is studded with particular proteins called GP120, and inside is a capsid that contains the viral RNA and viral enzymes. Initially, the GP120 protein on the virus is only able to bind to a cell surface protein on the macrophage called the CD4 receptor. A second receptor protein, CCR5, must also be present on the macrophage for the virus to enter the cell by endocytosis. Viral RNA and enzymes are released into the cell's cytoplasm. Reverse transcriptase uses the viral RNA to synthesize first a strand of viral DNA and then the complementary DNA strand. The viral DNA then moves to the nucleus of the cell where it integrates into the host cell's DNA. Transcription of the DNA within the nucleus now results in the production of viral RNA. This viral RNA can serve as the genome for new viruses and can be used as messenger RNA to produce viral proteins during translation by the ribosomes. Complete viruses are assembled and released from the cell via exocytosis, which causes little harm to the macrophage. HIV cycles through macrophages over a period of years and continues to multiply while doing little apparent damage to the body. Eventually, the gene that codes for the GP120 protein is altered by mutation. The altered GP120 protein changes its co-receptor allegiance and now binds to a different co-receptor, CXCR4, which is found on the surface of CD4 plus T cells. The same processes occur within the T cells, resulting in new virus particles. However, as these new viruses leave the T cell, they rupture the plasma membrane, which kills the cell. As these newly released viruses invade and destroy other T cells, the body's immune response is weakened, and this leads directly to the onset of AIDS.
So that video shows how at first the virus doesn't really affect the body, doesn't really hurt us, but then over time, eventually it starts to destroy those CD4 plus T cells. And if you remember, those T helper cells, the role that they play in our humoral and cellular immunity. So you can imagine if we don't have enough of those cells around, what it will do to our immune response. So immune problems start when that count, that CD4 plus T cell count, drops to less than 500 cells. And severe problems start when the count is less than 200. And just for reference, normal range is 800 to 1200. So once our immune system has dropped so much, then the patient is susceptible to opportunistic diseases, and that is what eventually will kill the patient.
When
The transmission of HIV occurs through bodily fluids such as blood, semen, vaginal secretions, and breast milk. So the most common is going to be unprotected sex. This is a timeline for untreated HIV infection. So it used to be thought that if you have HIV, it is pretty much a death sentence. But nowadays, with the treatment that we have, it is considered a chronic disease. So as long as you take your meds and you follow the treatment plan, you'll have a normal life expectancy. So let's take a look at this timeline. So if you look here, this is the time of the HIV infection. So this is when a person has contracted HIV. There is a short time where there'll be signs and symptoms of an acute infection, and then about 3 weeks to 3 months, that's how long it takes for an HIV antibody test to become positive. And then look, you have this period of asymptomatic infection. It can start around 2 months all the way up to 7 to 8 years of the patient not having any signs and symptoms of HIV. So at the beginning, if you didn't know that you were infected with HIV and you didn't recognize this acute infection that happened because it kind of has flu-like symptoms, then you could potentially have HIV for years without knowing that it's brewing inside of you. And then years later, you begin to have this symptomatic infection, but it's already advanced. And after that, then it turns into AIDS. And then this chart here shows the CD4 plus T cell count and the opportunistic diseases that tend to come at that level. So like once your count goes to 400, 300, 200, this is what you start to see happening. So these are the clinical manifestations of HIV through each of the 3 stages that we just talked about. So during the acute infection, the signs and symptoms actually look similarly to other viral infections. So like fever, cough, weakness, nausea, vomiting, diarrhea, forgetfulness, headaches, vision changes, pen-like sweats, and lymphadenopathy, which is enlarged lymph nodes. So if you have a patient that presents to the doctor's office with some of these, they may be overlooked, especially if it's like flu season. The doctor may just discount it as, having some other type of viral respiratory infection or something like that. But that's where a good history comes in to see if the patient does have risk factors that may warrant an HIV test. So then we're going to have that long period of that asymptomatic infection where it can be years without those signs coming up. So those high risk behaviors may continue during that time. And then once that symptomatic infection starts again, those CD4 plus T cells are closer to 200 now. HIV will advance to more active stage, symptoms become worse, and then you're going to get those signs and symptoms of more severe, like the fever, frequent night sweats, chronic diarrhea, recurrent headaches. So everything's kind of like exacerbated. So on this slide, I want you to remember some signs and symptoms that indicate deterioration, deterioration in status, which warrants immediate attention by a doctor. So if the patient presents with any of these, a new cough, increased fatigue, temperature higher than 102, night sweats, new headache, new visual blurring, recent change in mental status, new onset diarrhea, weight loss greater than 10% of previously recorded weight, or new skin lesions. All of these things require immediate attention. So these are some examples of things that can happen during that symptomatic phase. So shingles, persistent candidal infections, oral genital herpes, and bacterial infections, things that you normally wouldn't see, but being immunocompromised, these type of things pop up. So how do we diagnose AIDS? So AIDS is acquired immunodeficiency syndrome, and there is a diagnostic criteria that the CDC has established. And what it says is to be diagnosed with AIDS, you must have HIV and an AIDS-defining condition, or a CD4 count less than 200, and it doesn't matter whether you have an AIDS-defining condition. So an AIDS-defining condition, here are some examples here. Pneumocystitis, Girovesi pneumonia. That's a common one that you'll see, and then you can kind of read through these on your own. Skin lesions, Kaposi sarcoma, commonly seen when you're in the final stages of AIDS. And this is when the immune system is severely compromised. These patients will have recurrent infections. They're going to get cancer. They're going to have muscle wasting and other age-related cognitive changes. So the way that we test for it, it's going to be, there's several different tests, and you can kind of read through them. The major takeaway from here is that there's a certain time, a window, where they can be infected with HIV, but it's not going to show up on a test. And that is the dangerous kind of limbo area. And these different types of tests can detect it at certain times. So like this one, the NAT test can usually detect it 10 to 33 days after an exposure, versus the antigen antibody test, it can detect it 18 to 45 days after exposure, and so on. So that's what you want to keep in mind. If a patient has a negative result, then you may want to test them again in a couple months. And then once the patient is confirmed to have HIV, we are going to monitor their progression of that infection by checking their blood and checking their HIV viral antibodies, and we call that the viral load. We're going to check that CD4 plus count, and then we also want to keep an eye on their white blood cells, the red blood cells, and the platelets, because those values tend to be low. So HIV patients should start antiretroviral therapy, or ART, as soon as they're diagnosed. So these medications are very, very potent, but they are very effective when taken as instructed. So these patients, because of the potency of the medications, they often will have liver issues, side effects that affect the liver. And it's important that they take these medications consistently, because if you stop, the patient can actually become resistant to some of those therapies. And then there is some genetic testing that can be done to figure out certain strands, which can better help give specific medications for that patient. So this is table 22.3 from your textbook. It just gives some more details on drug therapy and the adverse effects that you may want to look out for. And just FYI, there are contraindications and some side effects that can happen with ART therapy and some over-the-counter medications like antacids, PPIs, and certain supplements. So you just want to be aware of those. And then drug therapy in a nutshell, the main goal is to decrease the viral load, to maintain that CD4 count. We want to prevent those symptoms and opportunistic diseases. We want to delay that disease progression, and we want to prevent them from transmitting it to somebody else. So this therapy should be started right away, as soon as possible after diagnosis, and the patient has to be educated and ready for this, because the plan is for them to take these medications forever, indefinitely. And this is expensive, and it doesn't work for everybody, and it has side effects, systemic side effects. So those are all things that need to be considered, and transparency. The patient needs to know these things. And if the patient adheres to the drug regimen, it can really halt that disease progression. It'll avoid opportunistic diseases, all of those things. So again, this is considered a chronic disease nowadays. So these are some of the long-term effects of patients that are taking ART. Again, we expect this to happen, and this is going to pretty much affect the whole body: kidney problems, heart problems, hyperlipidemia, insulin resistance, hyperglycemia, bone disease, acidosis, and lipodystrophy. That is where the fat kind of redistributes, in places that it not normally is. So a lot of side effects. And usually what happens if a patient experiences adverse effects and, it's kind of interfering with their daily life in some way, then the regimen will be changed. They're not going to stop the ART therapy. They'll just switch it out for another medication, because there are actually a lot of medications that they can kind of, do on a trial run and figure out what works best for that patient. So management, we're going to monitor disease progression. This is just kind of a recap of what we just talked about. manage symptoms. We definitely want to prevent further transmission of HIV, so a lot of teaching about that. And we want them to avoid those high-risk behaviors, and any signs and symptoms they need to report immediately to the healthcare provider. And for HIV, don't make assumptions about who may be at risk, because these pictures here, these 3 people have publicly said that they are HIV positive. So they may not look like what you would think of a person having HIV. It can really be anybody. You need to have a conversation. That's the only way to know if they're at risk, and you may need to, offer an HIV test. And a side note for HIV, you do need a consent to run that blood test. It's not something you can just add to whatever, blood they're drawing. They have to consent to that. And then patients that you do determine to be at risk, examples would be people who had a blood transfusion before 1985, if they are sharing needles, IV drug abuse, if they've had any of these types of sexual experiences, or if they already have a different STI, sexually transmitted infection, that leaves them at higher risk for getting HIV. So we want to do health promotion. HIV infection is preventable, so we want to avoid those risky behaviors. We need to have a culturally sensitive, language appropriate, and age specific teaching, because it can be a teenager, it can be an older adult who will need teaching and behavior counseling. It takes some practice to become comfortable talking about these kind of things. So if you need help, then reach out, So again, this is pretty much saying the same things we just talked about. We want to increase safer sexual practices, decrease drug use, decreasing risks work. So that's where we come into play. So needle sticks, we can get HIV from a patient via a needle stick. So we need to be really careful. We want to make sure you get tested, or the patient gets tested. And there's also something called pre-exposure prophylaxis, or PrEP. It's a combination of antivirals that has been approved to use daily to reduce the risk of getting HIV. And that is the conclusion of this module.